I thank the organization IACI for inviting me as a speaker, and all the previous speakers have made the floor ready for me. Everything is almost spoken, so some of the slides would be kind of a repeat. But evaluating of aortic and mitral valve and valve-in-valve of the similar spectrum, it's a spectrum of imaging. So a lot of points overlap between the two. I would mention as I go. Now, since everyone has already spoken, CT is the imaging of choice. Does anyone still have controversy on that here? No. So, we all use CT. Other than the gated CT, the valve-in-valve for aortic, valve-in-valve and mitral is similar to that of the native valves, acquisition software. What special interest you need to know is you need a high kVp protocol because the stent causes a lot of blooming artifact, and you can use all the algorithms you have for metal reduction artifacts. In addition to that, we'll start with a small thing. Why in the lot of bioprosthetic valves have been used in the last few years, and we are seeing more and more degenerations of this valve, and redo AVRs are coming up. And there are a couple of trials which I have mentioned there, the VIV registry and the partner to trial, which have actually shown that valve-in-valve TAVR have been the treatment of choice in suitable anatomy and high-risk surgical cases. So we started with TAVR in SAVR. Now we have TAVR in TAVR, TAVR in TAVR in SAVR. So there is a long spectrum of these valve-in-valves which have come up. Now, why is it slightly different from the native TAVR is because valve-in-valve has a different anatomy and a biomechanical consideration. So your anatomy, what you assess, is slightly different from that of the native valves. The most important point is most of these patients do have a history and have the valve which has been put in, what kind of a valve and the size. But when it's unclear, you need to identify what kind of a valve is put in through your imaging and also determine the size. Why is it important? Because patient-process mismatch is a very important point to consider here. So if you're going to put a very small valve inside a patient physiology, which needs, the size is too small for that body surface area, then you would probably land up with a restenosis. So that is one of the important points. Second is the anatomical risk for coronary artery occlusion, which is very, very high in cases of redo valves. So valve-in-valve, if you can see the graph, it's very high. It's about 2.5 as compared to the native valves. Now we start with identifying the valve. So how do you do that? You take MIP images. You can kind of, narrow down the window, demonstrate the valve, and zoom in and have a look at the valve. Now, this comes over a period of time that you can identify, but you don't have to actually. There are a lot of references which are available, which you can go through and identify the valve easily. I have shown you. And you can even see in the MIP, you can beautifully demonstrate the stent frame if it is a stented valve. Identifying the stent or stentless valve is very important. You have to know whether this valve is, how is the leaflet orientation, whether it is an externally mounted leaflet or whether it is an internal mounted leaflet. I'll come to that. Whether it is a fracturable or non-fracturable valve or whether it is implanted at an annular or a supraannular plane. Once you have done that, we'll go for the sizing. Now, these are a few references which I told you, which will help you identify the valves. There is also a very important app which you can freely download on your phones. It is called valve-in-valve app. It's available for both aortic as well as mitral, which gives you a detailed assessment of stented valves, how they will look, what are the sizes, and what is the next valve-in-valve suggestions of valves that can fit into it. Now, like in TAVI, even in valve-in-valve, identifying the basal ring is very important. And again, it is a non-planar basal ring which has 3 valleys. So identifying of these 3 valleys can be done on CT, where you start similar to TAVI, you position it on the aortic valve, and then adjust your coronal and sag images in such a way that you land up with a 3 valleys seen at equidistance. Once you kind of scroll down, these 3 valleys should disappear. Once you identify that, That is called as your landing zone or the basal ring. Sorry, I didn't know you were not able to see that. So that's the valleys I was talking about. It's a non-planar ring, and once you identify that based on placing the center line in the middle of the valve and rotate the coronal and sag images axis in such a way that you identify the three valleys at equal size and equal distance. Once you do that, when you scroll down, they equally disappear, and also you can check it by turning the two axes and identifying them in the coronal and sag view. When you do that, you identify the coronaries and you mark them with the pointers. Now, these are small videos which I have just loaded. In automated software, you can identify the aortic angle by putting lines. It's called the aortic axis. So once you do that, you go for identifying the ring. Now, the same procedure is done here also by tilting coronal and sag. Once you identify the ring, you will draw two short axis diameter as well as the internal ring. So importance here is you need to know that metal causes a lot of blooming, so you take your window to bone window. That will help you identify the ring better. You calculate the two inner diameters, perimeter and area. Now coming to knowing what kind of a valve you have put its importance is here, because the true diameter of your valve is not what you are calculating. So if you're going to be calculating an inner ID of about 29 and it is a valve which is porcelain valve, your true inner diameter will be approximately 2 mm less. But if it is a pericardial leaflet valve, inner and outer mounted, if it's an inner mounted pericardial valve, your true inner diameter will be about 1 mm less. If it is outer mounted, it will be equal to the size you have calculated. This is very important because once you identify that, you'll be able to size your prosthesis accurately. Prosthesis mismatch is, the incidence is as high as 2 to 20% in TAVR and even higher in valve, and increases the mortality and morbidity very highly. Now in valve, a small valve is considered when your valve is around 20 or 21 based on different frames which are available, and your index, more importantly, the indexed ejection orifice area which you can calculate on CT, if it is less than 0.5 centimeters per milli square for that indexed body weight, is considered as patient prosthesis mismatch. And this is important to know because they will use fracturing before implantation of the second valve, or they will prefer to have a supraannular implantation in case the coronary heights are higher. Okay. So you can at the same time have a look at the cine images. You can even see the orifice. You can see which leaflet is restricted, how much is the restriction. You can measure the orifice area like I told you and index it to the body surface area. In addition, you can look at whether there is pannus, where there is significant thrombus, which may need some kind of protection before you go in. Identifying of LA appendage thrombus as well as extrusion of LA is important in cases of mitral valve. Now, after we have identified the valve and calculated the sizes, we are going to see for anatomical risk factors for coronary artery obstruction. You first identify whether the valve is attached at the annular level or supraannular. Why this is important is because the coronary to the ring height decreases if it is a supraannular stitching. Again, the second important point is you look at the tilt of the valve. If the valve device is kind of tilted, whether it is tilted towards the coronary cusp is important because your distance between the valve strut as well as your coronary distance will decrease accordingly. Third important point is looking at your STJ. If it is very narrow, that could also cause some sequestration of your sinus because it's going to block at the STJ and there will be no blood flowing into the sinuses. Look at the leaflet calcification. If there are large chunky calcification at the leaflets outside the strut on the old thing, or if there is calcification over the valve, which is kind of projecting onto towards your sinus at the coronary sinus, is important to mention. We also take in all patients sinus of Valsalva, STJ measurements, as well as coronary sinus height and Valsalva heights. Now, identifying whether you are at risk of coronary artery obstruction is important to identify the risk plane. This is called as where your upper end of the previous stent ends. Now, if the previous stent ends below the coronary ostium, you are less likely to have coronary obstruction. But if your coronary height goes above the coronary artery ostium, the struts, the processes goes above the coronary ostium, you have higher risk of coronary artery occlusion. So what you do next is you calculate what is called as virtual valve to coronary distance and virtual wall to STJ distance. This is done by simulating a valve. So what you do is once you have got your valve size based on your diameter calculation, you create a cylinder of the similar size as the valve you are going to implant, and that is kind of shown here on the left figure. So again, like already the previous speaker spoke, you can have different depth of implantation, whether it is 20, 80, 40, 60, depends. In aortic, usually the lesser the better. So you usually go with 20, 80. You simulate the cylinder there. What happens is you get at the level of the coronary ostium in your cross-sectional area of your valve, you will get a cylinder, and you can measure a vertical distance from the wall of the cylinder, the virtual valve, to the coronary mid distance. This is called your vertical, this is called your prosthesis to coronary distance, the TVC. So it is also called as VTC in some cases. Now virtual ring to coronary distance of more than 7, the risk of coronary artery occlusion is very low. If it is lower than that, the risk of coronary. Once you have VTC of more than 4, the next point you're going to look at is your STJ, the virtual ring to sinuotubular junction distance. This is also done in a similar manner at the level of sinuotubular junction. And a cutoff of 2 mm is important to note here. Why this is important is already discussed with our previous speakers. A VTC of less than 4 and a VT STJ of less than 2 might need basilica. So this is very important to know. In addition to that, we can, with CT, we can define the implantation views and deployment views. We can also give them the projection views in which will be helpful for their basilica and commissural alignments. How do you do that? You basically kind of overlap the right and the left coronary cusp in order to non-coronary strut will be thrown onto another side. It is called as 1:2 view. And when you align all the 3 in a similar manner, where you can see this, the yellow, green, and red dots are in a same plane. That is called 1:1:1 view and called as coplanar view, useful for implantation. In addition to that, like TAVI, for all valve-in-valves, we do aortic access and venous access in cases of TMVR. Now, TMVR, there is not much to add in terms of assessment, which already Vineet has beautifully discussed. So I will just show you, as in native mitral valve, even in valve-in-valve TMVR, neo-LVT obstruction is a very high risk, and that has to be kind of addressed to when you're imaging it. And a similar way of aortic valve-in-valve, we do calculate the size of, identify the valve, calculate the size of the ring, which gives you an idea as to what processes is going to go into this ring. Only the difference is here the patient processes mismatch is at a higher, because the ring is usually, mitral rings are usually larger. So like it's mentioned that this software is very important in terms of mitral valve-in-valve assessment as well. So it goes in a similar manner as mitral. So I'll just be repeating in just a short thing. Same as native mitral valve, you identify the annular segment. So basically, you will identify the ring instead of the native valve, native annulus. So the ring is identified in a similar manner like you do in the aortic valve in valve. Once you have done that, you will also identify the angulation of this available prosthesis to the LA-LV axis. So it is called as mitral trajectory. Now the angle between the LA and LV and the angle at which the prosthesis has been implanted, if it is acute, there is less chances of your LVOT obstruction. As this angle increases, you see that the prosthesis is going to eject more into the LVOT and more chances of new LVOT obstructions can be seen.
You have 1 minute, Zeeshan.
Yeah. Virtual valve-in-valve stimulation, I'm not going to repeat myself. Vineet has already told. It is the same as that as the native valve. Here we just simulate a valve within the existing valve and calculate the new LVOT. So this is all a repeat for the same. Now coming to quickly bicaval valves, just 4 slides, I'll just quickly finish. So these are basically valves, bioprosthetic valves which are self-expanding and placed in SVC and IVC so that there is no caval reflex in cases of very severe tricuspid insufficiency. So my experience has been with trick valves or thing. I'll be speaking on those, how we assess them. They usually have SVC valve has a bulb in the center and the IVC valve has a short skirt towards the atrial side. They are neonatal stents with bovine pericardium. Now, here very important is patient preparation. Unlike any other valve-in-valve or structural cases, adequate hydration 1 hour before the CT is very important, and reducing diuretic regimen for about 24 to 48 hours before the CT is important. Why this is important is, if you are going to keep them in a dehydrated state, the amount of tricuspid regurgitation reduces, and whatever measurements you do of the SVC, IVC will be underestimated, and the valves will be kind of too small for the SVC and IVC. Second important point is the coverage. The gated study, what we take, is covered from the subclavian to about 8 to 10 centimeters below the diaphragm. We also take an additional venous phase non-gated study for access pathways. Reconstruction is the same as that of any other valve reconstructions. We use a double injector triphasic method. We use in a tighter dose as to 60-40 and 25-75 in 2 phases at 4 ml flow rate. Now, one more important point is you could trigger at around 70 to 85 seconds trigger delay, where you can see the IVC filling much beautifully instead of an early pulmonary or a late trigger. Cardiac modulation should be again done at end systolic, and you can do a prospective end systolic if there is no atrial fibrillation. These are the valves which has to sit into the SVC. So the important point is the belly of the valve has to fit above the level of the pulmonary crossing of SVC. This is a very important point to know because all your measurements are based on this. And you want to land it up as higher as possible and not jetting into the RA. And there is an angulation, I'll come to that. Ruling out all congenital IVC and SVC anomalies is very important in cases of trick valves. If there is a left-sided SVC or a PAVC, mention of that is very important. These are the few values which we do. So one is the first measurement is at the formation of the just beyond the brachiocephalic vein.
Can you conclude, please?
Yeah. Second one will be above the pulmonary artery. Third is below the pulmonary artery and SVC RA ostium. 2 lengths to the pulmonary artery and the complete SVC length is important. For IVC, you will need the length of suprahepatic IVC and length of 5 centimeters of the IVC diameters below at the level of IVC and at the SVC RA junction. Angulations of the SVC to RA at the level of RP is important. IVC to RA angulation at the level of the suprahepatic segment is important. 2 more notes to be made, that is the eustachian tube as well as interatrial septum. The distance of the intralateral septum to the IVC ostium should not be very close by. Any addition around the SVC is important because that will hinder the procedure. These are two articles if anyone wants to read further on the cable valves. And I conclude by saying that meticulous pre-procedure planning is very, very important in intervention cases. And proper history for the valve and valve-in-valve app are very useful. CT plays a very vital role in identifying coronary risk obstruction in redo tower, valve-in-valve towers, as well as neo-LVOT obstruction in cases of TMVRs. And patient preparation and a very good quality CT image is very important in bicaval valves. Knowledge continues to evolve, and we have to be continuously be developing new ways of measuring, and newer valves understanding is very important for planning. Thank you.
Thank you, Zeeshan. That was very, very good presentation. And I'm sure those of you who would like to, start with your first case will get a good help from this presentation. Any questions? Because we are running short of time, probably you can speak to Zeeshan about the questions later and we can go to the next session. Thank you, Zeeshan.
I take this opportunity to felicitate Zeeshan. Zeeshan, can you please come? Priya, ma'am. So thank you, Chairperson. Thank you for your time.